We are
Okay. So good evening, postgraduates, and welcome to this 61st episode of All India Postgraduate Teaching Program, an initiative from ARC AOS. This PG program, we boast of being different compared to other teaching programs because we have case presentations, journal clubs, OSCEs, and didactics rarely on topics which are not comprehensively available for you in a textbook. Last episode, if you remember, we had two short cases. Today is the 61st episode of this series and the 12th journal club since the conception of this particular PG teaching program. And in today's journal club, it was Dr. Kalya, who is a MS final year student at Shankar Nethralaya, Chennai, would be presenting the one article. And the second article would be presented by Dr. Shubhangi Goyal, who is a DNB resident at Narayan Nethralaya, Bangalore. I am sincerely thankful to mentors Dr. Ratini David, who is a senior glaucoma consultant at Shankar Nethralaya, Chennai, and Dr. Sushma Tejwani, who is a consultant at Head Glaucoma Services, Narayan Nethralaya, Bangalore, for mentoring both the postgraduates. My special thanks goes to senior discussants, Dr. G. Chandrasekhar sir, who is a Vice Chair Emeritus LV Prasada Institute, Hyderabad, Dr. Harsh Kumar sir, who is a Director Glaucoma Services Center for Sight at New Delhi, and my dear friend Dr. P. Satyan, who is a Director at Satyan Eye Care and Coimbatore Glaucoma Foundation at Coimbatore. Now, without much ado, can I request Dr. Kalya to share her screen? Dr. Kalya, you can get your video as well on and then share the screen.
Shashi is not responding. Dr. Kazabhi, hello.
Dr. Kalya, hello.
Please,
I'm
Dr.
asking her to mute. She's not unmuted.
What happened? She had shared her screen.
I'll call her, sir.
Let us try her mobile number.
I'll call her, sir.
Okay,
So we can start with Dr. Shubhangi, please.
Yeah, can we swap the presentation? We can have Dr. Shubhangi Goyal to present her article first. Dr. Tejwani,
Yes, sir.
is it okay? Sure. GC sir, with your permission. Shubhangi, you can share your screen.
Go ahead.
Yes, sir. So is it visible?
Yes, it is well visible. You can go ahead now.
Good evening, everyone. Before I start, I would like to thank everyone for giving me this opportunity to present at this platform. I'm Dr. Shubhangi Goyal, and under the mentorship of Dr. Sushma Tejwani ma'am, I'll be presenting the article for today's journal club. So the topic of my journal, for my journal club is the comparison of structural and functional features in primary angle closure and open angle glaucomas. The journal was published in the article was published in the Journal of Glaucoma in April 2024. So first of all, coming to a small introduction. So as we all know, leading glaucoma is the leading cause of irreversible blindness worldwide. The primary glaucoma is divided into the primary open angle glaucoma and the primary angle closure glaucoma, which will be denoted as POAG and PACG in the coming slides. So the primary open angle glaucoma is more common than primary angle closure glaucoma, but primary angle closure glaucoma causes higher degree of visual disturbances. As we all know, there are different underlying mechanisms of aqueous outflow obstruction. The PACG is due to the opposition of peripheral iris to the trabecular meshwork, which blocks the flow of aqueous humor, while POAG is due to the obstruction of the aqueous outflow due to an abnormality of the extracellular matrix of the trabecular meshwork or in the function of the endothelial cells of inner wall of Schremp's canal, leading to raised intraocular pressure. Just a small thing on the terminology. So the primary open glaucoma is where there is open angles on gonioscopy with elevated intraocular pressure without any secondary cause and with the presence of glaucomatous optic neuropathy. While the primary angle closure, we have three terms, that is the primary angle closure suspect, which is basically the iridotrabecular contact of greater than or equal to 180 degrees with normal intraocular pressure and no evidence of trabecular meshwork or the optic nerve damage. The primary angle closure means the iridotrabecular contact of greater than or equal to 180 degrees with elevated intraocular pressure or the presence of peripheral anterior synechiae, but there's no optic nerve damage. While the primary angle closure is primary angle closure glaucoma is the primary angle closure with the presence of glaucomatous optic neuropathy. So since the article talks about the two main a test that is generally done in the glaucoma patients. So there'll be a small introduction of both the tests. So first is the visual fields. So starting from the top, the report consists of the patient particulars, which consists of patient's name, his date of birth, the gender of the patient, and the patient ID for identification. Next, we see the type of test that has been done. So herein it's central 24-2 threshold, along with the eye for which the test has been done. Next, we see other testing parameters, which includes the stimulus size that has been taken, the strategy that has been used, the pupil diameter at the time of test, the visual acuity of the patient, while along with the refractive error that has been given to the patient at the time of the test. Then we see the reliability indicators that includes the fixation losses, the false positive errors, and false negative errors that are given in percentages. Along with that, at the bottommost of the report, we see a gaze tracker that shows how much the patient has concentrated. Then coming to the actual maps. So first of all is the absolute scale, which mentions the actual value of retinal sensitivity measured in decibels at selected points. Beside it is the graphical representation of the numerical value, which is represented in the various shades of gray. Next is the total deviation numerical plot, which gives us the difference between the patient's measured retinal sensitivity and the age-matched normal values at each tested location. Below the total deviation numerical plot is the total deviation probability plot, which is again the graphical representation of the numerical plot. Then comes the pattern deviation numerical plot, which is derived from the total deviation numerical plot itself and is used to identify the localized effects in a generalized field defect. And below it is the pattern deviation probability plot, which is again the graphical representation of the numerical plot. Then coming to the global indices, which includes the VFI, that is the visual field index, which measures the patient visual field status in percentage of normal age adjusted visual fields. Second is the MD, that is the mean deviation, which is the average of deviation of the total deviation map and has a negative value. Higher the value, the more severe is the deviation. Below it is the PSD, that is the pattern standard deviation. It is the index for measuring the variation of the retinal sensitivity across the entire visual field. So higher the PSD, more is the disturbance in the halo vision. Next, coming to the OCT RNFL. So it gives a cross-section of the circumferential imaging of the peripapillary RNFL. Coming again, so the topmost portion of the report contains the patient particulars, which includes the ID of the patient, the name, the ethnicity, the gender, and the date of birth of the patient. Then we need to ensure whether the scan is of reasonable quality or not. So that can be seen by the signal strength that is measured here in the green box, along with a color photo that gives provide us whether the nerve has been adequately centered or not, which is represented by the green circle. Beside it is the thickness map, and below it is the red-free filter image. Below the red-free filter image, there are average thicknesses given, average RNFL thickness, the total average RNFL thickness, the average RNFL thickness of the superior quadrant and the inferior quadrant. The main is the TSNIT plot with the RNFL thickness, which is compared against the normative database. The green part can show that it is green, that is normal. The yellow is the borderline, and the red means that the RNFL is thinned out below the normal limits. Below it is the quadrant-wise thickness map of the same, in which the numerical values along with the color coding is given. The bottommost part of the report consists of the disc topography, which tells us about the various disc parameters, the rim area, disc area, the linear and the vertical cup-disc ratio, and cup volume. So coming back to the article itself, so we'll be analyzing the article in the MARI framework, which is M stands for method, A for assignment, second A for assessment, R for results, I for interpretation, and E for extrapolation. So first of all, coming to the method, so to the hypothesis of the article. So the purpose of the article is to compare the structural and functional features in primary angle closure and primary open angle glaucoma. Now, the current article states no initial hypothesis. Coming to the population, so the study is a retrospective study, and the study population has been included from a US-based tertiary care center from a period of 2015 to 2022. The entire study population is divided into two groups, the PACG group and the POAG group, and the patients were identified according to the ICD-10 diagnosis codes. The primary open-angle glaucoma group consisted of patients having glaucomatous optic neuropathy with a documented open-angle gonioscopy and no evidence of secondary glaucoma. While the primary angle closure glaucoma group consisted of patients having glaucomatous optic neuropathy with the presence of laser peripheral iridotomy or the documentation of narrow angles on gonioscopy. If both the eyes of a same patient were suitable for being included in the study, only one eye per patient was taken, and the eye with the worst visual field mean deviation was included in the study. So now here we see that the study is a single center study. The primary open angle glaucoma group here consisted of both the primary open angle glaucoma as well as the low tension glaucoma, while the primary angle closure glaucoma group consisted of both the acute and the chronic angle closure glaucoma patients. Along with that, which is the strength of the study, is that the authors have done again a manual chart review on a random sample of 40 subjects taken from each of the group to confirm whether the diagnosis of the ICD-10 codes is correct or not.
So Shubhangi, here, now have they defined anything on severity of the group, severity of the glaucoma in any of the groups, in both the groups like that?
No, ma'am.
So it's an EMR retrospective chart review where they have looked at whether the angle is open or no, and there is some evidence of functional or structural damage, but there is no extent defined as to how much, which group had how much damage or what are the criteria in terms of severity, right?
Yes, ma'am.
Okay. And what was the idea of the manual chart review for 40 subjects from each group?
Ma'am, actually, they have not mentioned how were the ICD-10 diagnosis codes were taken into account to identify the patients. But however, they have taken after that, they had again done a random. They have taken random 40 subjects from each of the group and then done. And
So
then
have they defined how did they take the subjects, whether there's any method of randomization they had followed, how they picked up the samples?
no, ma'am. There's no randomization of the.
So that is good or bad?
Ma'am, that's bad.
Okay, go ahead. Go ahead, please.
Coming to the size of the study, so 283 patients with PACG were included and 4,110 patients were included in the POAG group. Now we see that is a very good sample size, but as we are seeing that there's a very vast difference in between the number of the PACG and the POAG patients that are included in the study. As we see that the POAG patients are approximately 14.5 times more than the PACG group. So to see whether this sample size was adequate or not, we did the study, and according to a study published in 2021, a meta-analysis was done in the primary angle closure glaucoma patients, and the prevalence of the primary angle closure glaucoma was seen in America, which was 0.7, while in a similar meta-analysis published in 2021, the prevalence of primary open angle glaucoma patients was 2.4, which comes out to be around 3.4 times. That is, the POAG patients are 3.4 times more than the primary angle closure glaucoma patients. In a study mentioned in the current article, This is a study published in 2014, which predicts the prevalence of the PACG and the POAG patients in 2020. So we see that the prevalence of POAG is estimated to be around 3.29, while the prevalence of PACG patients is estimated to be about 0.26, which comes out that POAG patients are around 12.6 times more than the PACG patients, while the study still takes around 14.5 times patients more as compared to the PACG group.
So what do you think would have caused that kind of a difference?
Ma'am, might be they would have missed out on the PACG patients.
So one is that's a possibility. It's a retrospective chart review. But the other thing that you mentioned in the beginning, like you have primary angle closure glaucoma, were both included or only primary angle closure glaucoma was included? And if you look at this prevalence, this is from North America, and the article is also from North America, I think Boston,
Yes,
right?
ma'am.
Whereas the prevalence that you had shown in the previous slide is from South America. So whether there's that much difference in prevalence is something, I mean, that is what is reported, so it should be. But still here the disproportionate disproportionate population of angle closure and open angle is quite starking. Okay, go ahead.
So coming to the assignment, so it's a retrospective study and the individuals were assigned using the already available data. In that also, one of the POAG patients had undergone the laser peripheral iodotomy elsewhere. Now, why this patient had been included in the study, we don't know. Since the POAG patients are already so much more than the PSAG patients.
This they figured out when they looked at that sample of random sample of 40
Yes, ma'am.
each group, right?
Yes,
Yeah.
ma'am.
Okay, go ahead.
So the confounding variables are the subjective nature of gonioscopy. Since the study is a retrospective study, so we can consider that the gonioscopy might have been done by different people. Also, the stage of the disease, since the study does not talk about the severity of the disease seen in any of the group. Since the study is a retrospective study, so no masking was done. Coming to the assessment part, so first of all, the parameters. So studies take into account the demographic parameters and the ophthalmic parameters. The demographic parameters included the age, gender, race, ethnicity of the patient, while the ophthalmic parameters included the global parameters, first of all, such as the spherical equivalent and the intraocular pressure. The structural parameters included the global RNFL thickness, vertical cup to disc ratio, rim area, disc area, cup volume, and the functional parameters included the mean deviation, pattern standard deviation, and the total deviation, along with the visual field index. Coming to the accuracy of the scans, so the OCT scans that were taken into consideration were among the entire OCT scans that were done for a patient. The most recent of the OCT scan was taken, and the signal strength was taken to be greater than or equal to 6. For the to ensure the quality of the visual field test, the fixation loss was taken as less than or equal to 33%. The false positive was taken as less than or equal to 20%, and similarly, the false negative was taken as less than or equal to 20%. Since it's a retrospective study, so there's more bias due to reliability of the collected data, the data entry, and the data quality assurance. Now, in the OCT scan, apart from the signal strength, it has not been mentioned in the study if the OCT was entered properly or not. While in the visual field, the fixation losses are taken to be 33% instead of the standard 20%.
Anything about learning curve or reliability of the visual field was mentioned?
Ma'am, they have not taken into consideration the learning. The author has mentioned it as a limitation itself, that the learning curve of the visual field was not taken into consideration.
So that means the most recent OCT scan and visual field also was taken was most recent.
Yes, ma'am. The most recent that has been in proximity with the OCT, like within a 1 month duration of both the things.
Shubhangi, can we go a bit faster so that we have adequate time for discussion?
Yes, sir. So a single scan of each patient was assessed for the study, so there was no requirement of the follow-ups. So the analysis was done as a univariable and the multivariable analysis. Coming to the univariable one, so continuous variables were tested using the t-test and the categorical variables were done using chi-square test, and the statistical significance was taken as p is equal to 0.05. So coming to the demographic characteristics, 283 patients of PACG were taken into consideration and 4110 patients, the POAG were taken into consideration. POAG patients were found to be much older than the PACG patients. As we see, the age of the average age of the PACG patients is 67, while of the POAG patients 69, which is not much of a difference. So the comparison should not be affected. The groups did not differ in the racial distribution of or ethnicity. A greater proportion of the PACG patients were female compared with the patients with the POAG group. As we see, the female percentage in the PACG group was 62, while in the POAG group was 52%. Now, whether this can affect the measurement of the RNFL and everything. So we read about a study. So it's a study published in 2024 in the American Academy of Ophthalmology, which mentions that the RNFL thickness is lower with the older age and in male gender. Coming to the baseline ocular characteristics, so the patients with PACG and POAG both had similar treated IOP, but the patients with PACG were more hyperopic compared to the POAG group. So as we see, the average spherical equivalent in the PACG group was plus 0.29, while in the POAG group was minus 0.96. And we know that with the axial length measurement, more the axial length, the RNFL thickness decreases. Coming to the results of the univariate thing. So the cup disc ratio, cup volume were found to be smaller in the PACG patients, while the rim area and disc area was found to be larger in the PACG group with a thicker global RNFL. In the functional differences, we saw that the mean deviation was similar in both the patients. The visual field index was also statistically similar in both the groups. The patients in POAG had a higher pattern standard deviation. Now, when comparing the total deviation values, patients with POAG had significant greater loss in the superior paracentral region, while patients with PACG had significant lower total deviation values in the inferotemporal region. But when these total deviation values were adjusted for structural damage, it showed that the PACG patients had worse total deviation values all across the visual field locations except for the paracentral region, and were more pronounced in the inferior hemifield as compared to the superior hemifield. Then coming to the multivariable analysis. So since the authors did not had all the values of all the patients, so only 90 patients of the PACG patients and the 16 and 1679 POAG patients were considered for the multivariable analysis. The analysis was done using the logistic regression analysis to predict the PACG and POAG group using the demographic and the global ophthalmic parameters and the quadrant RNFL thickness with the spherical equivalent and disc area. The Bayesian information criteria was used to remove the redundant parameters, and the strength of the association was measured using the odds ratio. So the baseline characteristics of this group of population also had similar values. The POAG group had older patients as compared to the PACG group, although this was not significant. Similarly, there was more female preponderance in the PACG group as compared to the POAG group, and the PACG group patients were more hyperopic than the POAG group. So to predict the PACG versus POAG using the demographic and the ophthalmic parameters, the demographic parameters included the age, gender, race, and ethnicity, while the ophthalmic parameters included the estimate of disease duration, the spherical equivalent, intraocular pressure as the global parameters, the global RNFL thickness, vertical cup to disc ratio, rim area, disc area, cup volume as the structural parameters, and the mean deviation, pattern standard deviation, and visual field index as the functional parameters. When the analysis was done and the patient information criteria was used, the demographic parameters, including the age, gender, race, and ethnicity, were found to be redundant. And in the ophthalmic parameters, the estimate of disease duration, intraocular pressure, rim area, disc area, cup volume, pattern standard deviation, and visual field index were found to be redundant and was therefore removed. Now the PACG group had more relation with the hyperopic, as in the hyperopic patients had more chances of having PACG with an odds ratio of 1.24 for the relating to the RNFL thickness. So PACG patients had more preserved inferior RNFL with an odds ratio of 1.15. The smaller the cilia, the more are the chances of PACG with the odds ratio of 0.69, while worse the mean deviation, more the chances of PACG with an odds ratio of 0.95. Again, in the results also, the authors did a manual chart
interest of
review
time,
again.
Yeah,
Maybe in the interest of time, you should move on to your conclusions
Yes,
so
sir.
that there is at least 5 minutes for discussion. What's the take-home message from the article for you?
Yes, sir.
I think that's what you should come to.
In the conclusion, the patients with PACG has less structural damage than POAG patients despite similar degrees of functional loss. So the PACG patients need to be treated more aggressively as compared to the POAG patients. At a similar degree of structural damage, more significant functional loss was seen in PACG patients.
thank you, Dr. Shubhangi. In fact, you are supposed to conclude it within 15 minutes so that we have adequate time for 15 minutes of discussion from the senior experts who are there to discuss and help you out in understanding better for you as well as the student at large. It's open for comments from all the discussants, Dr. Chandrasekhar sir, Harsh Kumar sir, and Satyan. Please. You can unshare the screen for a while.
So if I may go, I don't know whether I should go first or not, but if I may go. The criticism about the prevalence being more and more number of patients of angle closure, open angle glaucoma compared to angle closure glaucoma being there, probably will not be valid here because the study hypothesis is essentially to compare the structural parameters in both the groups with the functional parameters being same. So even if the larger sample size is there, because the mean deviation and the VFI were similar between the two, the pattern standard deviation having a p-value of 0.01 has no significance because with Bonferroni correction, since you are comparing 4 or 3 functional parameters, that p-value is not significant. So you can take that for a given amount of damage in the visual field, the structural changes as measured by OCT are less in angle closure as compared to open angle. I think that's a valid conclusion. But my own main takeaway from this is that the limitation of looking at the structural parameters only with OCT. OCT is basically limited. While it can quantify what you are seeing, it has no color value at all. The most important point in angle closure glaucoma is that because of the intermittent raise in intraocular pressure, this is my understanding, there is less cupping but more pallor. So if pallor is indicative of damage and you are not measuring the pallor at all in OCT, you are missing out the structural damage that is taking place in angle closure glaucoma because you are only going by the RNFL thickness and cup disc ratio. So based on that, if there is a difference in the pathophysiology, the authors have talked about the vascular versus non-vascular there. But in my own sense, it is intermittent versus continuous raise in intraocular pressure and the component of vascular in the normal tension glaucomas that may be there, which are included in the open angle glaucoma. In fact, I had a couple of patients who were referred to a neurologist by ophthalmologist to rule out as the primary optic atrophy. because we don't check the pressure properly, we don't do gonioscopy properly, we mistake the disc damage in angle closure glaucoma to be primary optic atrophy also. So that's my take.
Sir, would that mean that angle closure, we should depend more on the functional damage than the structural damage?
Structural damage as measured by OCT is not complete structural damage, is the point that I'm making. Structural damage as measured by a color fundus photograph or a clinical evaluation is equally important.
Yes.
So basically, sir, I think you had taught this to us before also, that I think for the postgraduate, the most important thing which comes out of this is that if you feel that it is glaucoma and yet you find that the discs are not cupped enough, I think you have to go back and look into the angle. And it much may be an angle closure glaucoma. And secondly, like you rightly said, sir, because many a times we also, if we maybe the patient has not done fields correctly and there's no time to do another fields. But yes, if there's a field damage inferiorly and yet the OCT is normal, I think that is one of the very prominent things which comes out of this. Then one would have to really look at the angle and say that yes, you cannot neglect just because the OCT is green. So I think very rightly put by sir.
And the other important thing to remember with angle closure glaucoma in our context is that the AC may not be shallow, the iris and lens changes may not be there. It is only gonioscopy that will pick up the diagnosis of angle closure glaucoma.
And yes,
And angle closure glaucoma with the room darkened and pupil being allowed to dilate to its maximum and then deciding whether it is open or closed. The objective of gonioscopy should not be to look at the trabecular meshwork. Should be to assess the gap between the cornea and iris first and then the angle structures.
And very rightly put, sir, even Von Erich sometimes is very deceptive. So you rightly said sometimes the angle may look deep and yet when you do the gonioscopy, you realize it's all closed.
Yeah. Von Erichs and myopia are not contraindications for angle closure.
Dr. Satyan, any comments from you?
Yeah. The only thing which was a little interesting was in an angle closure, those he said the disc size in the OCT is bigger than the POAG. That is an interesting finding. But in spite of the disc size being bigger, she mentioned that the RNFL thickness was more in the angle closure disease, which is little deviating from the actual things. Because once the disc size is more, the RNFL thickness will be usually a little lesser. So that is the only thing which I am seeing in this study as little interesting to look at. So otherwise, what Dr. GC sir was saying is kind of we have to look into the angle closure, we have to look into the pallor, because that is one of the indicators how high the pressures possibly could have been in angle closure disease. So that is another added feature that one has to look into. Because sometimes the cup may be small, but the disc may be having a pallor. So we may think the patient is normal, but truthfully speaking, it is not normal. So we have to really look into that as one of the most important findings.
So this difference in the size of the disc is not different between the two groups. 1.96, 1.90, P may be
Yes,
0.03. Once again, because there are so many parameters that are being compared, 0.03 is not significant.
Yeah.
You can't go by the standard 0.05 when so many parameters are being compared. You have to do Bonferroni correction, and with that, the difference in the disc size is not significant between the groups.
If I may add one thing is that this OCT was done by I think Cirrus, and the differences what we are seeing as p-value less than 0.001 in all anatomical parameters are in the range of say 6 microns or 5 or 6 microns, whereas the resolution of Cirrus is 5 microns. So whether that is also significant is also a question.
Okay. Sir, any more final comments, sir? Or
No, I
should-
think everything is covered. We have already taken 4 minutes of the other presentation.
No issues. Thank you. Thank you, GC sir. Thank you, Dr. Shubhangi. You presented well, but you exceeded the time. No issues. We need to learn from each presentation, and you will definitely do well in the next one as well. So, Kyle Vizi, are you ready now?
Yes, sir.
Yeah. You're mute. We can hear
Yes,
you.
sir.
Remember, you are supposed to present your overall article within 12 to 15 minutes so that we have adequate time for later to have a discussion as well.
I understand.
Okay.
Yes, sir.
Share your screen. Make it in a presentation mode.
Yes. So is my screen visible?
Yeah, now we can see, we can hear you as well. Please go
Yes.
ahead.
Thank you, sir. Good evening to all the mentors on the forum. I'm Dr. Kyle Willi, a MS resident at Shankar Nethralaya. I'll be making a presentation on the article Glaucoma Intensive Treatment Study, which is a randomized controlled trial. My mentor for the day will be Dr. Ratni David. So the Glaucoma Intensive Treatment Study is a randomized controlled trial comparing intensive and standard treatment on a 5-year visual field development. So this study is used to assess the effect of an intensive initial IOP lowering treatment on the progression of visual field damage. So as always known, clinical randomized trials have the highest evidence of the positive effect of intraocular pressure reduction on the course of open angle glaucoma. So the goal of open angle glaucoma to maintain an intraocular pressure within a range at which visual field loss is unlikely to proceed. And target IOP is an estimated upper limit of the IOP range, which are compatible with the treatment goals. As understood, target IOP is an estimate or a guess estimate, and adjustments are always made to the originally chosen target intraocular pressures. So determining the perimetric rate of progression over a period of 2 to 3 years, where at least 5 visual field tests are required to determine the rate of progression. And even with frequent testing and optical interpretation tools, the mean deviation index have already been worsened by 2 decibels before a definite progression event can be confirmed. So this initial intensive treatment, which was proposed, aimed at a larger initial intraocular pressure reduction, a true target intraocular pressure which was reached more rapidly, so that the progression of the disease was slower, the patient had fewer clinical visits, and it was deemed to be cost effective as to have a low IOP in all glaucoma patients. However, the initial intensive treatment would have a higher cost for the glaucoma medications, potentially more local and generalized side effects, and a risk of always a poor adherence. So this study aims at studying the effect of intensive initial treatment in comparison with the escalating strategy that we usually use, starting with a single IOP lowering drug. So this aims to compare and report the effect of 2 treatment strategies on the progression of visual field damage. This also aims to mimic ordinary clinical care as far as possible, where as in there are no intraocular pressure inclusion limits, changes in the treatments were allowed as and when necessary, and there was no masking. The study design is a prospective longitudinal 2-center parallel group open labeled. It is done in accordance with good clinical practice standards, which adhere to the tenets of the Declaration of Helsinki. The individuals who were newly detected, previously untreated, manifested open angle glaucomas were randomized to 2 groups. First group were a conventional stepwise escalating treatment starting with a single IOP lowering medication, and the other group was an intensive treatment group where IOP lowering eye drops from 3 groups were started simultaneously, followed 1 week later by a 360-degree laser trabeculoplasty. So the following inclusion criteria were done. Patients of open angle or pseudoexfoliation glaucoma patients, patients between 40 and 78 years of age, and there was no upper or lower limit applied to the untreated intraocular pressures. Pigment dispersion patients were excluded from the study, and visual field loss at presentation less than 65% of a full field were excluded. Medical conditions which prevented the participants for the follow-up period were excluded. Pregnant women, nursing women, and childbearing age women who were not using contraceptions. And if the patient had any contraindication for any of the glaucoma medications, they were excluded from the study. And previous eye surgery except for an uncomplicated cataract surgery, were not included. And conditions that could affect the visual field, except for a mild diabetic retinopathy, are excluded. So the total follow-up period were 5 years, which included 12 clinical visits, 6 visits during the first year, 2 visits yearly up to 3 years, and yearly visits thereafter for 5 years. So these are the set of minimum necessary visits, and extra visits were always allowed if necessary. The randomization was done on a 1:1 ratio to the 2 initial treatment regimens. They was performed in a randomized block sizes stratified according to the type of glaucoma, whether they were open angle or pseudo-exfoliation glaucoma, and according to the center. So the interventions, the monotreatment group received either a prostaglandin analog or a beta blocker. The multi-treatment group, any type of a combination drop, the typical presentations being bimatoprost timolol combination or a travetone timolol combination, plus a drop from the third group, usually a brinzolamide or a dorzolamide. 1 week later, after starting the 3-group drug, a patient was subjected to a full 360-degree laser trabeculoplasty. In this study, it was majorly selective laser trabeculoplasty in 82% and argon laser trabeculoplasty in 18%. So depending on the eligibility, one or both the eyes could be included in the study. So to assess, since they were on multi-treatment, to assess the difference in the signs and symptoms of ocular surface disease between the treatment groups, a proposal was done to add 3 diagnostic tests to the protocol, which were to be performed at the last visit: the tear breakup time, the Schirmer's test, and the staining using the Lissamine green. Primary outcome was measured with the final visual field status between the 2 groups. Perimetry being the most adequate test to measure the changes in the visual function. Using perimetry, 3 different analyses were performed, which was the rate of progression of visual field damage, the remaining visual field at the projected time for end of life, and the finding of definite progression in the visual field loss as defined by the EMGT progression event analysis. Secondary outcomes were measured in terms of visual acuity, intraocular pressure reduction, adherence to the prescribed treatment, adverse events, and the serious adverse events. Also, vision-related quality of life, signs of ocular surface disease, and adherence to the prescribed medications, data were collected and documented. Regarding perimetry, 2 pre-study visits using the 30-2 CETA standard strategy implemented in the Humphrey Field Analyzer was done. The first visual field test is usually a training test and it is not included in the analysis of progression. The second test, if reliable, is used as the baseline test. And a minimum of 10 visual field tests are done, the second pre-study visit and 6 in the first 2 years. Extra visual field tests were always done if necessary. So vision-related quality of life was measured using the National Eye Institute Visual Function Questionnaire 25, which was evaluated at 1 month of study, 3 years, and 5 years of study. The intraocular pressure is measured at each visit using the Goldman acclination tonometer. Visual acuity measured in the logMAR scale using at the ETDRS chart at a distance of 4 meters. The first visit using an autorefractometer, refraction was noted, and participants at each visit were asked about the side effects and the serious adverse effects. All the changes in the IOP lowering treatment through the course of the study was documented. The patient's adherence and the subject's adherence to the prescribed medications, adverse effects, serious adverse effects, and serious adverse effects further graded as mild, moderate, severe, all were documented and reported. So an interim analysis was done at 3 years of follow-up, and that analysis showed that the rate of progression of visual field damage was significantly lower in the multi-treated group than in the mono-treated group. No stopping guidelines were specified and treatment could be changed or intensified according to the interim analysis. The study sample size was based on the progression of visual field damage and the amount of visual field damage at the time of diagnosis. So a sample size of 240 participants, 103 to each treatment groups were allocated. So that the study had a power of 80% with an alpha error of 5%. And also assuming a participant attrition of 15% during follow-up. Analysis was done according to the intention to treat principle, that is the treatment group to which the subjects were initially assigned. The perimetric rate of progression to analyze, we need at least 5 tests to be calculated by linear regression and EMGT event analysis for a finding of definite progression. And patients who withdrew from the study before 5 field tests could be done, they were not included in the progression analysis. Except 2 participants in this study, no participants were lost to follow-up and no imputation of missing data was performed. So in 186 participants, they contributed 1 eye each to the study. And in 556 participants, both eyes were eligible and they were included in the study. So projected visual field index at the end of the life, the values were found to be skewed. And the difference between the mono and the multi-treatment participants were compared using the non-parametric Mann-Whitney test. Rate of progression in the study was calculated by the linear progression analysis. Rate of progression analysis was presented as median values with a 95% confidence intervals. In participants in which both eyes were enrolled, then the mean of the 2 rates of perimetric progression were included. The Mann-Whitney test was used for the comparison of the distribution of the rate of progression values in the 2 treatment groups. So a definite progression of glaucoma was defined with the same criteria as used in the EMGT. So at least 3 significantly deteriorated identical points in at least 3 consecutive visual fields. Kaplan-Meier survival analysis was applied to compare differences from the baseline to the progression event. And if the progression events were flat in both eyes, the time for the first progressed eye was included in the analysis. So, and the overall comparison, the Kaplan-Meier survival between the 2 groups was conducted by the Log-Rank-Mantel-Cox test. The baseline IOP was the mean of the 3 values obtained on 3 separate visits, one in the 2 pre-study visits and one in the baseline visits. Again, the distribution in the baseline IOP was positively skewed and so it was presented as median values with 95% confidence intervals. And for categorical data, Pearson's chi-square test was used and p-value less than 0.05 was considered to be statistically significant for the study. Recruitment began in the March of 2013 and ended in the March of 2017. 242 newly diagnosed with previously untreated glaucoma patients were enrolled. 118 participants were enrolled to the initial mono treatment group and 124 participants to the multi-treatment group. Median age at baseline was 68 years, ranging from 46 to 78 years. In the mono treatment group, 2 participants withdrew from the study and 9 participants had died through the course of the study. In the multi-treatment group, again, 2 participants withdrew from the study and 3 participants had died through the course. So eventually, 107 participants in the mono treatment group and 119 participants in the multi-treatment group completed 5 years of follow-up. And there were 9 subjects who withdrew or died after completing the 5 visual field tests and they were added in the analysis. Depicting this as a flow chart, randomized to the total number enrolled was 242 and allocated to the mono treatment group was 1.
Important.
Yes,
These details may not be important. You need to move a little faster.
I'll scope. So the baseline characteristic of all the participants were more or less similar in the 2 groups. Family history of glaucoma was not statistically significant with a p-value of 0.30. In the multi-treatment group to be noted are the sleep apnea and the participants with diabetes mellitus and with vascular hypertension were in the higher level. Otherwise, the eye baseline characteristics were similar and primary open angle glaucoma, the percentage was 70% in the mono treatment group enrollment and 73% in the multi-treatment group, and pseudo exfoliation 30% in the mono treatment group and 27% in the multi-treatment group. The projected remaining visual field at the end of life, considering all the participants, the mono treatment group, the visual field index percentage was 79.3 and in the multi-treatment group it was 87.1. So this had a p-value of only 0.15. If you do a subgroup analysis in the baseline where the baseline IOP was more than 24 millimeters of mercury, the p-value becomes slightly more significant with 0.07. Rate of progression of visual field damage.
Can you go back to the previous slide?
Yes, sir.
Sorry to interrupt you, but I think this is the most important data point from the whole study.
Yes, sir.
Okay. The difference in the VFI of 79 to 87 is, even though it is not statistically significant, it is clinically very meaningful.
Yes.
The difference between 86 and 89 in the IOP less than 24 is clinically not very meaningful. And the difference in the IOP more than 24 from 74 to 85 is very highly significant. So this point that in the patients who are with higher baseline IOP, multi-treatment is going to be more useful than in patients with baseline IOP less than 24, I think is an important conclusion that comes through, though it is not statistically significant. Sorry, go ahead.
Yes, sir. The rate of progression of visual field damage, again in all participants, it was monotreatment group was 100 and almost minus 0.65, and in the multi-treatment group it was minus 0.25 with a statistical significant p-value of 0.09. In the event analysis of visual field progression, which depicts the progression of visual field loss across the time, the number reaching the criteria for visual field definite progression event in the monotreatment group was around 21%, and in the multi-treatment cohort was around 11%, which showed a p-value of 0.03. And this difference was most pronounced in participants with higher baseline IOP. The intraocular pressure evaluation. In the monotreatment group, the initial IOP reduction was around 7 millimeters of mercury, and in the multi-treatment group, the IOP reduction was around 12 millimeters of mercury. And the IOP difference did not statistically change over the 5-year period. Since there were many drugs that were included in the second group, the adverse events in the monotreatment group was around 29, and in the multi-treatment group, the numerical number was around 45. So they were categorized further as mild, moderate, and severe. To be noted is that the severe adverse effects were reported only in the multi-treatment group in 2 participants. So the development of visual field damage is just in a newly detected, previously untreated pseudo-exfoliation or a primary open-angle glaucoma patient who were randomized to either of the treatments. And there's been no previous studies which compared this effect on the progression of visual field where one group had one drug and the other group had multi-drug combined with the laser trabeculoplasty. So there was 2 other studies which compared primary laser trabeculoplasty and IOP lowering medications earlier. The CIGT test where initial surgery with initial medical treatment were analyzed. And there was a recent study which showed primary trabeculectomy versus primary glaucoma eye drops in newly diagnosed advanced glaucoma patients. And none of the previous studies have shown any difference in the treatment arms. In this current study, the visual field status at 5 years of follow-up was better in the multi-treated group. The end-of-life visual field values, whether real or predicted, was again better in the multi-treated group. The number of eyes ending up below the visual field index 50% was the same in the 2 groups. Computing, the rate of regression was 2.6 times faster in the monotreatment group than in the multi-treatment group, which had a p-value of 0.09. If you do a subgroup analysis, which included only candidates with higher baseline IOP, the rate of progression was 5.5 times faster, and that had a borderline statistical significance, 0.06. So the larger sample size showed a statistically significant difference, and the per protocol analysis, where you excluded 4 patients who showed poor adherence, the significant difference in the rate of progression became 0.047. So in subjects with higher untreated IOP, the median rate of progression was 5.5 times faster in the mono group with a p-value of 0.06. And with per protocol analysis, where you exclude those 4 patients who didn't adhere to the drug properly, then the p-values become 0.054. The progression event analysis again shows a favorable effect on the multi-treatment participants, and particularly in participants who had a higher pre-treatment values. So the difference was that 5-year analysis, the eyes with higher baseline IOP, progression in monotreatment group was 5 times more. And there was no difference in participants who had lower, this difference did not show up in subjects who had lower untreated IOP values. Intraocular pressure reduction was again larger in the multi-treated group than in the monotreated group. The adverse effects and the number of patients reporting the adverse effects was 37% in the multi-treated group and 25% in the monotreated group. Probably this difference might have been larger if the treatment had not been increased in almost 50% of the initially monotreatment participants after the interim analysis. So computing the strengths of the study could be, it is done on newly diagnosed and previously untreated participants. And the study had a very low attrition rate, and there was predetermined criterion for visual field progression events. The criterion for definite visual field progression as in the EMGT. So this removed the risk of subjective interpretation of progression. No IOP limits were applied. And this was designed to mimic ordinary clinical care where you can always change the treatment whenever needed. The limitation would be because there was an imposition of a minimum baseline visual field index value where less than 65% were not allowed to enroll. And all the participants were European and the results could not be generalized to the non-European patients. So this study projected the level of glaucomatous field damage at the predicted end of life based on the 5 years follow-up data. So intensive treatment versus stepped approach. Whether could one drug be added at a time and you analyze how much IOP could be reduced. That could be difficult in the clinical setup because variations in the intraocular pressure in treated eyes makes it difficult to evaluate the effect of one extra drop with one single IOP reading. So this study recommends where in clinical glaucoma care where visits can be more delayed, patients are more lost to follow up with less frequent field testing could be done in the clinical setting. The initial intensive treatment in patients with higher untreated intraocular pressures may be of larger benefit in clinical care. Whereas in patients with lower baseline IOP, the study recommends an escalating strategy starting with a mono treatment, which could be sufficient in a large proportion of glaucoma patients. So MARI, the methods were good, prospective longitudinal 2-center parallel group. Sample size was good overall, good follow-up to detect progression, and assignment was good, good randomization, stratification was good. The assessment was good again. Data collection methods were clearly defined, valid measurements were taken, statistical tests used were appropriate and were clearly defined. The results were fair, where the difference in visual field index 0.15 and rate of progression for a p-value of 0.09, though not statistically significant, but event analysis significant difference was noted with a p-value of 0.03. For the subgroup analysis, a larger sample size was required. The interpretation was fair. Intensive initial treatment delays progression, particularly in high baseline IOP patients, and recommended a stepwise escalating strategy for a large population of glaucoma patients who had a lower baseline IOP. Extrapolation is fair, where it cannot be generalized to a non-European patients. Longer follow-up was required to predict lifelong outcomes and could not be applied in patients with baseline visual field index of 65%. Thank you, sir.
Well presented, Dr. Kayalvizi. Now,
Thank you, sir.
may I request all the discussant, Dr. GC sir, Dr. Harsh sir, and Satyan sir to join for the discussion.
Dr. Kayalvizi, excellent presentation, really good. Can I ask you a couple of questions? Did you check why 18% of the patients were done ALT, because the machine of SLT was very much there? And why 19% of the patients are put on timolol instead of PG analogs?
So the study did not mention anything particularly why it was done, sir.
And
It could be done possibly to mimic clinical care.
Okay, and is it possible that, yeah, that's a good point. Is it, have they compared, because you see, by the time people come to us in India, they are already on medications. So it is, have they also compared that the higher visual, the patients with higher field pressures were having worse visual fields? Have they given anything like that?
Meaning higher the comparison
with more than 24 millimeter pressure, were their initial visual fields worse?
Nothing mentioned like that. It's just mentioned those who are, if it was worse than 65%, then they were not included.
That is for the whole group.
That was for the whole.
Because many a times in our patients, they are already on treatment, and we are looking at visual fields to try and set our parameters for the target patient. Okay, thank you.
Yeah,
the study was on
the initial.
These were all treatment naive patients.
Yeah, but I'm saying for the
they have not.
I'm just trying to extrapolate to my country.
Yes, sir.
Because at least they could have correlated the visual fields with the patients who were having the worse IOP. Though obviously we can think that maybe they were having the worse visual fields with a higher IOP, but I was just wondering.
They have not stratified the severity of the glaucoma, sir.
Yeah.
Yes.
And also, if there were a difference between the pseudo exfoliation group versus the primary open angle glaucoma group, also would be better, because we know that in exfoliation the IOPs are much higher in comparison to and also the fluctuations are going to be much higher. So the progression also is going to be more. And what is interesting for me is where I visit the other countries as well. So the problem is everywhere they usually start with the multi-drug or the combination of drugs, because the one is the problem is the availability, and other one is they just start two drugs as a combination in most of the places. What we have seen is the complications with the multi-drug, especially the conjunctival hyperemia or the other issues like a OSD is much more common. The issue is the failure of trabeculectomy that we need to always think about. And also the second part is whenever we give multi-drug, we really do not know whether both the drugs are effective or not. Always try to use a single drug, and probably we can add one more drug and see that both the drugs are first of all effective. So that will be one take home which I would advise, rather than just looking at this study and then we should not go and start those who are just about 24 IOP. We should not be starting on two drugs. It is important that we try to achieve the target pressure, whatever the stage of the disease, and then we look at those points, and then we can go for the combination of therapies. There is nothing wrong in that. But just straight away starting two drugs at a time may not be the ideal one to look at.
Yeah, thank you, Satyan sir. Dr. GC sir.
So I think the important thing in this study is that this is a study that has followed all the consort guidelines for a randomized controlled trial perfectly. So the MARI analysis, I would have put everything as good rather than as fair. You can't find a better randomized controlled study than what they have done. The second point, I think, is the so-called guidelines. I would disagree with Sachin here. So-called guidelines of starting one medication, see whether it is effective or not, and then add the next medication, like you very rightly pointed out, is you cannot keep doing a diurnal at every time, and with one pressure recording, you cannot change the treatment paradigms. The take-home point for me, which I've been following all through, is that if the patient presents with a very early glaucoma, and the patient is available for you for follow-up, then you can follow the guideline of starting one medication, seeing how effective it is, and then decide whether you want to add a second medication or not. With the kind of practice that we have of patients coming with fairly advanced damage and with very high IOPs, you cannot go through that paradigm. My thing would be the patient's IOP is likely to be controlled with a combination of 2 or 3 drugs. I will start all 3 drugs, if that is what my guess is. And then I will put them also on Diamox at that time. And then see whether I can get the target IOP in the shortest possible time. If I'm not getting the target IOP in the shortest possible time, then I need to escalate to the next level of surgery relatively fast in patients present with significant damage. From the study point of view here, because they are randomizing to different treatment paradigms, they have excluded patients with significant visual field damage at presentation. Only those that had a VFI of better than 65 is what they have included. That is not the kind of cohort that we see typically. The point about is the trabeculoplasty, Harsh, they have done trabeculoplasty for all the patients. SLT in 82%, ALT in 18%.
Yeah, I was wondering why ALT, sir.
Huh?
They had the machine over there. Why?
I think it's the question of availability probably in that particular time. They have done in 2 different centers. So it's probably the question of availability.
GC sir, I was not trying to say that all the patients, because the IOPs, if it was higher, obviously all of us do start on multiple drugs, including the Diamox. I was just trying to say that those who are not really required to have a multi-drugs. like the IOP is say 25, probably we may not be really going in for every patient to go with the 2 drugs or 3 drugs. That is what I was meaning,
we agree
not
with
like
each other. Thank you.
30s or 40s.
We agree with each other. Thank you.
Thank you.
There is no difference.
So an SLT is supposed to work better in treatment naive patients. So maybe that's why the multi treatment group did better.
Again,
Then,
they have
and they have not mentioned in the mono treatment when the treatment was yeah, they've immediately 1 week later they've done the SLT, sir. So and they've not so we probably don't know if SLT is the reason why that group fared better. And also they have not mentioned if in the monotherapy, if it has been intensified to just drugs or even if they've done
Your voice is breaking, Ratini.
Yeah, Dr. Ratini, your network is poor. Can you just shut your video so that we have a better
patients.
audio output?
Yes,
Doctor,
sir.
please, and then you
Now,
can
sir, now
you-
can you hear, sir?
Yeah, better.
better.
Okay.
Please repeat yourself.
No, sir, the multi-therapy group has had SLT on, so maybe the SLT had a greater effect on these patients than the drug itself, because SLT is supposed to work better in those who are treatment naive.
Dr. JC sir or Harsh sir, your comments on that?
No, I think it is possible. We cannot differentiate between whether the medical treatment is working better or SLT is working better. But the whole logic is that if you, instead of going the stepwise that is classically described, if you do everything that you can do non-surgical, can you have better visual field preservation compared to the so-called standard guidelines of starting 1 drug at a time? And from that perspective, I think this is a very useful paradigm for clinical practice.
Sir, but like you rightly said, most of our patients, by the time they come, they have quite a bit of damage. So again, I think we will have to go with multi-drug therapy in most of these cases. And the initial naive pressures are not really known to, I think it hardly we get a patient who is not being treated has come to us. It's very rare. So this, do you think that this study, because we have already been taught, even you have taught us that the risk factors for taking an aggressive approach is a higher untreated IOP. So what does this I know it's a very beautifully done study, and I think maybe the first of its kind in this fashion. But does it add really anything much to us, sir?
It adds a lot to the European glaucoma guidelines.
Okay.
Where they tend to do medical treatment first, start only 1 medication, ensure it is working before you add the second medication. If the medications are not working, then go to laser. If the medication and laser is not working, then go to surgery is their guideline. But for us, it is different.
Yes, that's what I was thinking.
Even for us, I think we still have patients who probably do not have the disease, but have been labeled as having disease because of NCT or OCT.
Very much.
So if you establish an early disease in them, then there is no point in doing the multi-drug treatment in them. Then you can probably do a monodrug treatment and then probably do a diurnal also to see whether you're getting the best possible pressure control or not, and then decide what you want to do. So that end of spectrum is different from the other end of the spectrum where they present with significant damage.
Right.
So we have both the groups. We have to individualize the patient. No, the main point is probably either of these two treatment paradigms do not fit to all the patients. We need to individualize the care.
Probably the LTP would have helped in the fluctuations in those patients who had higher fluctuations. That could have possibly helped also for the lesser progression.
Yeah, actually, they have not
Yes, sir.
proven that. So it is all
So
conjecture.
since that is not the study question and they have not submitted the data, we cannot make those assumptions based on this data. That is our gut feeling. We can have that feeling, but we cannot extrapolate that feeling to this data. That's the point I'm making.
But none of the results were statistically significant, sir. Is it because 5 years may not be a long time to?
The rate of progression results are not statistically significant, but the proportion are grossly different between when you take the group in the IOP more than 24.
Yes, sir.
So even if it is not statistically significant, that group also, even if it is not statistically significant, the amount of huge clinical difference that you have is what you have to go by.
Any more discussion? Any more points? Okay.
The only point is you will start doing glaucoma practice, no, Prashant?
No, sir, still I'm confused.
With ARC.
I hope he doesn't start putting stents.
I can't dare to do that because I really cannot differentiate the optic now, the trim and the cup and all those things. Still now, my focus is towards lattices and holes. And nowadays on vitreomacular interface more so. Beat. So I think we had a good discussion today, and everyone, Dr. GC sir, thank you for being with us. In fact, every one of us learned from you because you are a father of glaucoma, I think, in our country. So it was always a learning process for all of us. So I think we can conclude with your permission. So postgraduates, you were so lucky today to have Dr. GC sir, whom we fondly call Dr. G. Chandrasekhar sir, whom we fondly call GC, Dr. Harsh Kumar sir, and Dr. Satyan. They are all big stalwarts in the field of glaucoma, besides our own mentors, Dr. Ratini and Dr. Sushma. So thank you, both the mentors, for guiding their students so well. Yes, Dr. Kyle Vizi as well as Shubhangi for making a bold attempt to present. And you did a fantastic job. Ahead of this all stalwarts, I would be more stuttering compared to the way the fluently you presented. I congratulate both of you. And of course, both of your proud mentors, Sushma as well as Dr. Ratini. And my special thanks goes to all the three mentors for sparing their valuable time for the postgraduates who are the next generation of ophthalmologists for our country. Thank you once more. So postgraduates, we will be meeting again on following Thursday with something new. Till then, it's time for us to say bye-bye. Thank you one and all. Thank you, sir. Thank you.
Thank you,
everyone.
Dr. Prashant, and wonderful presentations. Congratulations to both the presenters.
They really, this generation is definitely more smarter than us. I would have definitely.
Absolutely, yes. Absolutely, absolutely. Yeah. Thank you.
Thank you. Great.
Right.
Thank
Thank
you.
you.